Hello, welcome to this webinar. I wait for 1 more minute because we just opened the room to make sure that all people, or most of the people, have arrived on time. So let's start. Welcome and thanks for being here with us today. I'm very proud to open this launch of the Civil Society Monitoring Report on Harm Reduction in Europe, which we organized now for the fourth time by Correlation European Harm Reduction Network. Again, this has been super work in the past months, not only the data collection, the whole process from starting, developing the questionnaire, the data collection, the analysis, the reporting and the writing, and now the final publication. It has been a lot of work, and it is always when something is finished and we can present it, it's something to be very proud of. So my function today is only to be here and to open the webinar and the launch, so I want to be short. I just would like to address a few things which we consider as important. So one thing about the process of data collection. What I said already, this is the fourth report. We started in 2019 with the publication of the first one, and since then the report has been adapted and improved, not only by us from the team, but also in close cooperation with the focal points who really contributed actively, and also the scientific advisory board and our research partners. We are very happy to have the focal point with us because, I mean, it's very clear our work and the whole monitoring depends on their input and on their active involvement. What I said, again, not only when it comes to the collection of data, but also when it comes to the input before, when we develop the framework or the questionnaire. Follow up. So we present this report now, but the idea behind the whole monitoring is not only to collect data and publish a report, but mainly also we wanted to have something in hands which could support us when we do advocacy work and also improve our practical work. So what I hope for and what we are aiming for is that we use these results, the report, not only at European level, but also at national or local level. You will see today that we also have will publish 10 summaries in different languages. So one summary, but available in 10 different languages. And I think this can really help you when you are at local level, at national level, to share these results. So I would like to invite you to really use the summaries or also the whole report and use it for your advocacy and local support. And if you would need our help and support in this, we are happy to contribute. Challenges, I would like to address that shortly as well. We know that our work is depending on funding, and last year in 2022, in the beginning, we were in the middle of a very insecure funding situation, and we were not sure if we would be able to actually continue with the monitoring. And this is also the moment where I would like to thank again two of the Finnish organizations who provided us with a small but still meaningful and very important funding, which allowed us in the first months of the year to actually continue with the monitoring. And the organizations who did that was EHIT and A-Klinika in Finland. And again, I'm very happy that they supported us in this. Later on, we heard in March, we heard that our operating grant was continued. And again, now we are in a similar situation. We don't know yet if we will receive funding for the network in 2023, but we are confident. So let's see, but I think this is what we share as well with all our members and with the focal points as well. And we see that our focal points are struggling sometimes as well when funding is being reduced or not really big, that also the respondents to the monitoring work is not so easy. So again, we appreciate that people are still doing this and are also considering the monitoring as an important thing for their work. Also, they are facing really big challenges sometimes in their country. I'm nearly there, so I'm closing now. I would like to finalize and with a number of thanks to important people. So first, again, the focal points, which really without them, no monitoring would be possible. Also, the Scientific Advisory Board, which helps us to also review the monitoring framework. The questionnaire contributes actively and helps us to see where we could add something or where we can create more impact or synergy with other actions. I also would like to thank our research partners, which is Daan van der Gouwe from the Trimbos-Instituut, who has written the chapter on new drug trends, and Tuukka Tammi from Finland, from THL, who has been writing the hepatitis C chapter. And last but not least, I would like to thank our team, which is Rafaela, Rigoni, Iga Jeziorska, and Roberto Perez-Gallo, who all three worked very hard on the report and on the publication, on the communication, and especially in the last days, there was a really loads of communication in the social media, not in the social media, in the WhatsApp groups and in the emails. So there was a lot of work being done in the past months. So I would really like to thank them. And those who are more familiar with our report from the previous years might have seen that we have a different graphic design. So we are very happy with that one as well, and would like to thank Jesus Roman for doing this. He's our new designer, graphic designer. And for now, I would like to close and I give the word to Rafaela, who takes over.
Thank you very much, Katrin, and good afternoon, everyone. Thanks a lot for being here with us today, for joining us. It's a pleasure for me to be again here presenting our civil society-led monitoring, now the data report for 2022. So my name is Rafaela. I'm the Senior Academic Officer at Correlation, and together with other colleagues, I've been leading the monitoring. And I will be your moderator for today for this first part of the webinar. So just to give you an idea on the program, in this first part, I will very briefly introduce the monitoring, and then we will hear from the authors, their highlights on what is happening with essential services in harm reduction, access to hepatitis C testing and treatment, and new drug trends. And then in the second part, another panel together with the authors will further discuss the implications of these results for different communities and from different perspectives. Can you kickstart, please, the presentation, Roberto? Yeah, the first slide is perfect. Thanks. So before we start, just some housekeeping issues. So feel free to use the chat if you wish to introduce yourself, say where you're coming from, and also interact with each other. If you have questions, your questions are super welcome, and we want to include them in the webinar also at the end of each panel. So please, if you can, post them in the Q&A, so it's easier for us to keep, and for the panelists also to keep track on the questions being asked. I think that's it for now, and the housekeeping. So can we go for a next slide, please? So here is our monitoring report for 2022. This is the fourth of the series. And as Katrin was mentioning, the major objective of this report is to provide data on harm reduction in Europe from the perspective of civil society organizations, so complementing other monitoring efforts that already exist. And we believe that data is power, and monitoring provides tools for holding governments, societies, and donors accountable. And also, we firmly believe that people delivering the services and those receiving the services should be at the forefront of defining what types of data should be collected, how harm reduction and the implementation of harm reduction should be monitored. And that's why we do this monitoring together with focal points and all the others that were mentioned by Katrin already. Can we go for next, please? So here you see some of the executive summaries that we have. So besides the report with all the data and all the explanations, we publish an executive summary. This year we translated in 9 different languages, so it's available in 10 languages. Specifically, the summaries are intended to further the contributions in local advocacy in the regions where our FPs focal points work. If we can go for next, please. So this is a map where you can see how our monitoring effort is a collective effort. Here you can see all the focal points that we have and their contribution in the last 4 years. So this year we had contributions from 31 European cities and 29 countries, more than 100 organizations. So the focal points do not operate alone. They also ask partners and other experts in their city or region to contribute. And for you to have an idea, most of our focal points, they are providing harm reduction services or running advocacy and policy activities, trainings. And most of them, as you can see in the map, have contributed for all the 4 years of the monitoring report. And they constantly give input on themes that we should focus on, methods, the indicators which you use. So as Katrin said, without focal points, monitoring wouldn't be possible at all. And we are deeply thankful to them. More people contribute to the monitoring as well. And so this include the expert groups. So we have this year expert groups for hepatitis C, for essential services in harm reduction and new drug trends, and they will revise the report. They will give ideas on the survey and on the indicators for this. So thanks to them as well. As Katrin mentioned, also the Scientific Advisory Board will oversee the whole methodology and look at the report. Our office will support with everything that is needed to make the report happen and to make the report coming out and being used for advocacy. So our thanks to everyone and our new graphic designer, as Katrin mentioned, Jesus. And so I would like now to go to the second part, already thanking our authors, Iga, Tuukka, and Daan. And first I would like to invite Iga Jeziorska to join us to present her highlights about the availability of essential harm reduction services. So Iga is a research officer at Correlation, and she's also chair of the working group of the EU drug policy of the Civil Society Forum on Drugs. And for you to have an idea, in the essential harm reduction services, we look at what types of services are available for focal point in the cities the focal points are, with attention to different subgroups of people who use drugs. And Iga chose some highlights to discuss with us today. So Iga, the floor is yours. Please tell us more about what you have chosen.
Yeah, thank you very much, Rafa, and welcome everybody. Thanks for being here with us. Can I get the highlight, the first one, please? So yes, the first, I think, interesting issue that is worth mentioning in the essential harm reduction services are the differences between the availability of safer smoking kits and safer intranasal kits in the cities where our focal points work. I've chose this aspect because so we've looked at the changes between 2020 and 2022 this year as well. And this is one of the very few, two of the very few actually services that we see kind of improvement of the situation in. So it is unique in that sense, contrary, for example, to delivering services for certain populations like sex workers, people experiencing homelessness, and so on. So as you can see, the proportion of, so the black color is the proportion of focal points that answer that they do not deliver this kind of services at all. So in both cases, it can be seen that it decreased significantly since 2020. And at the same time, the proportion of focal points reporting a great extent and somewhat extent of delivery has increased, as it can be seen in the very dark and middle dark blue color. However, and this is also related to the change or maybe expansion of methodology that we've introduced this year, this picture doesn't seem so optimistic as this graph said. And this is because the interviews that we've conducted also with 25, I believe, focal points say that still harm reduction services do not catch up, are not able to catch up very well with the changes in the drug markets and with the changes in drug use patterns, which means that most of them are still focused on injecting use and opiate use, and do not have services dedicated to people who use different types of substances or use other routes of administration. So yes, I would say that this information here on the graph gives us some hope regarding the improvement of the situation potentially in the future, but we are still not there yet, according to the experts that we interviewed. So that would be the first issue. The second highlight that I've prepared, if you can just try to ignore the HIV services, I would like to talk about the new category, and this is also the reason of choosing this highlight, because needle exchange programs in prisons were not addressed by our surveys and by monitoring report in the previous years. And this year we've introduced this category for the first time. And as you can see, the situation is not very optimistic or not developing very well. More than 60% of focal points reported that NSPs as not needle exchange programs are not available in their cities at all in prisons. And this is also kind of like in line with the general other information that we have regarding the situation in prisons, with exception of opioids substitution or opioid assisted treatment, because this seems stable over the years. However, people, so delivering services according to our focal points to people in prison settings has been over the years one of the categories of subpopulations where this delivery is the most difficult. So the services can be delivered to them to the lesser extent, and the naloxone in prison also is quite hardly available according to our focal points. What is also interesting is that compared to 2020, this year or last year, 20% more focal points reported that they do not know if naloxone is available in prisons in their cities or not. So this proportion went from 0% in 2020 to 20% in 2022. What's the reason for it? Well, that would need a little bit more digging, but also with respect to naloxone in prisons, and this is also the data that came from the interviews, and it also kind of proves that including more qualitative interview data gives really different aspects and different dynamics of the situation. Naloxone in prisons normally, it seems, is not available in prisons as such, but only in some context. People are given it upon release in the package that they receive when they finish their sentence. Yeah, so that would be it, I think, from my side.
Thank you so much, Iga. I think that really highlights as you said, that we see that harm reduction insists in being the more traditional type of harm reduction, with assisting people who inject opioids mostly, and there's a lot of still improvement, but still lacking services in other places. And I know this is not in the slides, but I know this is in the report, so I just wanted to ask you if you have any ideas, or I could get any insights into why that could be, because we also ask people about whether they can assist certain types of populations, and to what extent, and if not, why they think that's it. So are we talking about lack of funding for this specific harm reduction activities that are not HIV related, that are not necessarily, or that are not opiates related necessarily? Are we talking about lack of knowledge on how to handle the team? Can you give us some insights on that?
Sure. Lack of funding is definitely, for across most populations, lack of funding is the leading cause of troubles or challenges in delivering of services. But also in some countries, mainly, let's say east from Berlin, it's also political and policy environment that is not very favoring more. So it's not favoring such harm reduction services that are not directly related to prevention of HIV or hepatitis C. We had conversations with many focal points, and some of them say strictly or directly that if it wasn't about HIV prevention, that there wouldn't be harm reduction in their country at all. So yes, funding most of all, and then hostile political, policy, legal environment.
Thank you very much, Iga, for these highlights. I see one question. Okay, is a question about methodology, and whether that the methodology has been improved over the years, and if there's any new developments envisaged by the team. Do you want to give any highlights maybe for the specific part on harm reduction essentials?
Mm-hmm. Yeah, sure. So yeah, we've introduced a collection of the qualitative data last year through interviews to address several issues that were previously addressed only with the survey, to get a little bit more of in-depth information on that. And for the future, we also plan to keep this idea, to stick to it, but probably we will focus on one, maybe maximum two themes or topics per year that we explore more in depth, because simply, otherwise the report would be extremely long, and to really get detailed, specific information, in-depth information, we need to limit ourselves to one or two topics per year.
Thank you, Iga. And if I may add, one thing also that we are doing is trying this year is city reports. So focusing more on the situation on one specific city as a request of our focal points to improve advocacy at the local level. So that's another, and probably the other authors could give more explanations to this as well later on. Well, thanks a lot, Iga. Because of time, I think we go now to our next author. I would like to invite Tuukka Tammi to join us to present his highlights on the access and availability of hepatitis C testing and treatment among people who use drugs. And Tuukka Tammi is a researcher and program director at the Finnish Institute for Health and Welfare, and is chair of our scientific advisory board. Tuukka, please, the floor is yours.
Thank you, Rafaela, and good afternoon from Helsinki. Check that you hear me and even see me. Is that so? Yes, okay. So the hepatitis C part of the monitoring report and the related overall questionnaire consists of 25 questions on the availability of services and access to services, but also about the use and impact of national guidelines and other strategic documents that has to do with people who inject drugs and potentially have hepatitis C. We focus on the potential changes in the continuum of services compared to the previous years, and also to some extent to the role of harm reduction services and NGOs who serve people who use drugs in this context. I have chosen two figures from the hepatitis section of the report. Here's the first one, and has to do with the rapid testing or quick testing. In other words, it is about in which settings and services hepatitis C is being first tested and found in different cities. Please do not change yet, but I already mentioned that the second figure I've chosen is about treatment, about where hepatitis C infection can be treated in different cities taking part in the monitoring. And why have chosen these testing and treatment settings, services, figures? Because we know that to eliminate hepatitis C among people who inject drugs, we need a clear increase in both testing and treatment places also outside the specialized care, like infection clinics and hepatology clinics. So we are following how is the progress in increasing testing and treatment also in harm reduction services, in addiction clinics and general practitioners and so on. Also prisons and other more limited services. Okay, as this figure shows, the general development picture is that testing has not increased last year, and quite the contrary, it has decreased in many services. For quick testing, there was an increase only in self-testing and at GPs. So it's not very good progress. It's rather a negative one. We have also another question and figure on confirmatory testing, which is after the quick testing, of course. It's not here, but you can find it from the report. And I can tell that there was an increase in that only in prison settings. So the overall picture is same than from rapid testing. No increase, and in many settings decrease in testing. Then let's go to the next one about treatment sites where hepatitis C can be treated in case of people who inject drugs. And like before, people who inject drugs are most commonly treated for hepatitis C at infectious disease clinics and gastroenterology clinics, and this is quite natural and expected. But what is worrying is that last year there was a decrease in all other treatment sites for people who inject drugs. Treatment provided at harm reduction services and community services decreased even from 25% to 20%, which is a huge decrease. Of course, regarding both testing and treatment results from monitoring, we know that both from the hepatitis section of the report, but also from other parts, that still during 21 and 22, where this data is from, there were still quite a lot of COVID-19 related restrictions in many countries and cities, and also in harm reduction services. So this might be the main explanation for the negative progress. We can only hope that next year the situation will normalize and even gets better, so that the good development will continue so as to reach the global elimination targets for hepatitis C elimination. I think I'll stop here and we can continue in the panel section about this also. Thanks.
Yes, thanks a lot, Tuukka. It's very interesting to see that we had progress, but we still need much more in terms of community-based testing and treatment. But I will leave that, as you say, that discussion for the panel for the sake of time. I would like then to call, last but not least, Daan van der Gouwe to join us to present highlights on the latest new drug trends according to our focal points. And Daan is a drug researcher at Trimbos-Instituut and coordinates our expert group in new drug trends and the harm reduction, National Harm Reduction Network in the Netherlands. Not sure you were talking about that then, but so to have a broad idea, the new drug trends chapter look at the emergence of new substances used by new groups, new routes of administration, new combinations, changes in target groups, and more. But Daan will present us the highlights that he found most interesting this year. Floor is yours, Daan.
Thank you very much, Rafaela. I would like to thank first the correlation team, especially Jesus, I think, for the very nice design you have chosen for this year's monitoring report. It's really nice, this blue and the yellow stuff. It's really nice. So, Roberto, please, can you give me the slide? It's just one slide that I'm presenting. We have been monitoring new drug trends for the last 4 years or so, and ever since we started with that, it was a bit of a problematic issue, since the response was usually quite low, although the data presented was really interesting, and the number of, the feedback was really low, and this year it was even lower than before. As you can see on this slide, you have to make a little calculation, but in the end, the blue zone means 5 focal points out of the 30, I don't know, 30 something, 31, I think, really filled out something or mentioned, yes, something has changed in our city in the last year. And then more or less the same is for the emergence of new substance, known substance, but new among some of the target groups of the focal point. So yeah, there's a little, there's not so much happening, it seems. I doubt it basically whether it's true or not, but looking just at the results as they came back from the questionnaires, it's only a few people, a few focal points that usually fill out something. That could mean a number of things. It could mean that the markets, the local drug markets, are really stable. Nothing much is happening within the time span of 1 year, and also in terms of availability of substances. Maybe that takes more time. Like maybe 2 or 3 years for things to change, for new drugs to really emerge. But it could also mean that maybe focal points have a lack of time. This new drug trends is in the lengthy questionnaire, probably the last chapter. So it requires some time and energy of the people who are filling in the questionnaire. So maybe it's a lack of time or a lack of interest. I don't know. But the way we have done it so far doesn't seem to be very suitable for this type of data collection. However, we have been starting with focus group discussions in the last few years with several focal points, and that seems to be really very interesting stuff to gather data on what's going on at the local level. The advantage, one of the advantages of group discussions is that you are able to actually set up an interaction, to ask questions and to ask more questions and clarifications and so on. In a questionnaire, that's simply not possible. It's a one-way direction, and sometimes it's even quite difficult to understand what people fill out in the questionnaire. So focus groups seem to be, in our opinion, the future for new drug trends. So I'm quite positive about the future of this specific topic, and I think we will be able to gather more qualitative and more data anyway. One thing, because my presentation is really short, the thing I would like to conclude with is it's this issue is problematic in its nature because, you know, I am lucky to live in the Netherlands to be working actually with drug checking service for many years, and our drug checking service exists for 30 years, fully subsidized by our government. However, this is more or less a unique situation. There's more and more drug checking services in Europe, but it's not geographically spread, properly spread. So some countries have a lot of them. So in now, for instance, France as well. But there's still many countries and at least cities, there's many cities that do not have any possibility for drug checking. So people basically have no idea what they are consuming, what they're buying, what they're using. So this really hampers the quality of the data of the drug checking, the new drug trends part. But also I think here with organizing focus group, we will be able to retrieve better quality data. So I'm very positive and open for any questions or remarks. Thank you, Rafaela.
Thank you very much, Daan. I don't see questions in the Q&A so far. So maybe I think we can go directly to the second panel and to have a more variety of discussions and questions from the panelists. So I would like to call back the authors and call Alexei to moderate the second part of the webinar together with the other experts. And Alexei Lahov is director of the development of the charitable fund Humanitarian Action and our focal point also at Correlation. I would also like to call Southwell, who's a technical advisor and also project coordinator at EuroNPUD. And Perrine Roux from the French Institute of Health and Medical Research. And please, Iga and Tuukka, if you can also join. And now, Alexei, the floor is yours.
Thank you very much, dear Rafaela. Thank you very much to the participants of today's webinar on such an important topic as the presentation of the Civil Society Monitoring Report on harm reduction in Europe. And you have already heard about harm reduction essentials, about hepatitis C situation, and about new drug trends in Europe. And in your opinion, what are the implications of these results for different communities and stakeholders? And what are the implications of these results for advocacy and for harm reduction overall in Europe? So let's make this panel conversational. Let's chat a little bit, and I would like Perrine to start this important discussion today. So the floor is yours, Perrine. Could you start, please? Do you hear me? Can you hear me? Okay. I would like to give the floor to Perrine Roux.
Yes. Hello, thank you, Alexei. I'm a public health researcher working in Marseille, and I'm very happy to be here and to have been invited to comment these results of the correlation monitoring. I have many comments, and I think it's a short time to address all these comments, but I will try to give you my main comments and question. First of all, I would like to congratulate you to have conducted such a huge work. It's a good overview of access to harm reduction services in Europe, and I think it's very useful for advocating to have more access and adequate services. So first of all, regarding the methodology, but you answered my question. But I was wondering to what extent this methodology gives us a representative view of what happened in a country. But now I think you decided to have a more focus on a city instead of the country, which I think it's good. And also Daan explained the importance of conducting focus group. And I think we have already talked about that in Athens. And it should be an interesting way of having more stakeholders involved in the monitoring and having a more representative view of what is happening in the country. So regarding the part presented by Iga, I liked the choice you made by selecting just some points of the report, and I understood very well why you decided to choose the services of safer smoking kits delivering and safer intranasal kits, because we know the situation of injecting opioids, harm reduction services, but I think we need to adapt harm reduction tools to stimulant use. So this is interesting to have the percentage of access to these tools. And I was wondering if the COVID period may have impacted the access to this kit, sniffing kit or a smoking kit, just to compare these results to a study that I'm working on with Coalition Plus. I'm sure you have heard about Coalition Plus, which is a coalition of HIV organization. And I worked with them to analyze the data they collected among people who use drugs from all of this organization. I don't remember exactly the countries involved in this analysis, but we found that the factor associated with decreased access to services, harm reduction services during the COVID period was not related to opioid, but more other products, drugs. So it's interesting because it shows that we know how to have an access and to stabilize access to harm reduction dedicated to opioids, but it's more difficult for other drugs. Well, it's just an hypothesis, but it's interesting to have these results. Then the results regarding access, yes, in prison, NPS in prison. This is, of course, the main points of these results, and it will deserve, I think, to have more detailed findings according to each country to be able to advocate for having a needle exchange program in prison. Then, do you want me to go until the end of my comments, or to do step by step, Alexei?
Could you go to the end of your comments?
Okay, thanks. So for the hepatitis C part presented by Tuukka, very interesting also results to understand how people have access to hepatitis C testing. So beside the overall decrease of hepatitis C testing in the main services, we have a main access in harm reduction programs, which is quite expected. But 2 points. The issue is that hepatitis C testing harm reduction programs are not in all of the cities, and in rural parts of some countries, it's difficult to have access to harm reduction programs. So it would be important to increase access, to have more data on how to improve access in general practice or sorry, in pharmacies. This is interesting to see, not an increase, but yes, that it could be a possibility of access. And also regarding our work on access to harm reduction services among women, I wonder if you have data according to gender, but I'm not sure. What we found in some qualitative and quantitative studies that we conducted, it's that women have more difficult access to hepatitis C testing, and through the qualitative interviews that we conducted in Marseille, and I'm sure it's the same in other setting, women, they have some difficulties to go to harm reduction program because they're a minority and the services are not adapted to their specific gender issues. So I think that's also an important point, and that's why having access to pharmacy, general practice could be a way to have a good access for women. In terms of treating, so it's quite surprising to have an increase in more medical services, because I would have expected to have an increase in harm reduction services program, because we know that on-site treatment, treating where people who use drugs are, has been presented are a very effective way of increasing access to treatment, but it's not the case in that results. And we have an increase in general practitioner, which is a quite good result. And to finish with the Daan presentation on new psychoactive substances. I was in Athens at the restitution of the results, and I understood that the questionnaire was difficult to answer, or I don't know, people were not very willing to answer this questionnaire, not very sensibilized in this question. I would request or suggest to perhaps to involve more people with drugs association or forum of people with drugs on website. I know in France some psychonauts, psychoactive, and here we would find some interesting results on new psychoactive substances, and to have more precoce results on these new trends, because often you have people from the field who are either not connected with people who use new NPS, or people who know only very severe complication due to NPS, but in the middle, we do not have any information. So it would be interesting to have more people with drugs organization to fill that gap. And just to finish, we are submitting a European project on drug checking with 10 countries. So I hope this project will help to evaluate, promote drug checking, and to have more information regarding these new psychoactive substances. So I think, yes, I finished. Thank you, and if you have questions, here.
Thank you very much, dear Perrine, for your insightful comments and remarks. And now we are going from the academic perspective to the community perspective. And now I would like to give the floor to Matt Southwell from EuroNPUD and COACT. Matt, could you please share your views, your thoughts on the results of these reports and on the implications of these results on the harm reduction situation in Europe overall? The floor is yours.
Yeah, thank you, Alex. Look, firstly, to all our friends in correlation, congratulations on a really useful piece of work. I think it's this starting to have really clear, regular data on what is happening in harm reduction is part of the community accountability that we need to create with each other. And I'm pleased to see that happening. Firstly, I'm commenting from a UK perspective where we're seeing a really worrying trend post the pandemic of a 25 to 40% drop in needle and syringe coverage that hasn't gone back up since the pandemic. It looks like drug users have basically taken the message when harm reduction wasn't prioritized and wasn't seen as an essential service. Drug users have picked that up, they've adopted their practice, they're starting to go back to reusing and sharing as a normal part of practice, and they haven't re-engaged in services. So I mean, I hate to use my own country as a way of commending the rest of Europe, but unfortunately this is a situation that we find ourselves in, which is, you know, being in Italy recently and looking at the work of the Red Cross, having spoken to colleagues in Germany, where harm reduction was made an essential service and was maintained and continued through the pandemic, where outreach services were sustained, they haven't seen this drop-off in needle and syringe coverage. And I think it just really highlights the risk of disrupting harm reduction services for very marginalised populations. One of the few areas in the UK to not just sustain its needle and syringe coverage, but to up it was my hometown, where drug users mobilised together to actually give out needles and syringes through local drug suppliers and through the people running local drugs houses. We give out 60% of the needles and syringes in our local area now. And that's been critical to sustaining harm reduction, and also critical to managing the impact of an arrival of cocaine injecting, which we know from Glasgow, from Belfast, has been really associated with potential outbreaks of HIV. I'm really sorry to use my country as a cautionary tale. This is what happens when you deprioritise harm reduction, defund harm reduction. And look, it's heartening to come and see our European colleagues not falling for that mistake and actually sustaining harm reduction services and seeing things continue on a generally upward trend around harm reduction. I'm incredibly envious as a drug user from the UK. So that's one part of the story. I think the other part of the story, which I think is always difficult to capture, and I think it's something I would encourage you to think about, picking up on Perrine's comments, which is how do we capture peer-led harm reduction? Now, we often have people providing focal point engagements that generally look at the professional response to drugs, or the systematic response. And I think the peer-led response can often be much more invisible. And I think as we build our own drug user networks and start to work with correlations on other types of intelligence gathering, I hope we can better map that in future years, because one of the messages of the pandemic is that community-led really worked. We sustained naloxone access, needle and syringe program access, engagement in Hep C testing and treatment. All of that's been backed up by having strong peer-led models. Not saying it's the only approach, but it's saying it's an important part of a fully scaled up approach if we're really to break through this sort of 30% needle and syringe coverage, which remains pretty consistent across Europe at this point. I think I'm slightly concerned to see the trend around the medicalisation of the Hep C process. I really think we need to be pushing out with self-testing and dry blood spot testing and peer-led blood spot testing. No, we're really excited to be working with Correlation on the Boost project, where we'll be able to document some good practice around peer-led testing in Norway and in Portugal, and then spread that learning over the period of the Boost project. And I think, again, it's always a trend to push back towards a much more formal biomedical system. Hospitals are good at raising money, doctors are good advocates, and we tend to put stuff within secure systems where it can be well managed. The problem is that tends to leave the most marginalised struggling to engage in services, and I think we need to continue that conversation. I think generally there's also a conversation around stimulants. Really happy to hear this continued focus work on MPS and looking at the trends around this. So thank you, Dan, for that focus. Yeah, I mean, I think within that context, I just wonder about some of the conversations around drug checking. Not so convinced about fentanyl strips, to be honest. I think a lot of peers, even though I know the people who've developed this work and have done it with real robust commitment in the US, we're also seeing that as fentanyl becomes established, fentanyl testing becomes less and less effective, because if it's the only drugs around, very few people are going to actually throw their drugs away, even if it tests positive to fentanyl. And then as people get fentanyl habits, then they have to use fentanyl. So I think we have to have maybe a more sophisticated response to the arrival of synthetic opioids. And I think the current situation in Estonia, where we're starting to see the arrival of very specific types of new synthetic opioids on top of their existing fentanyl issues. I think Estonia probably is going to continue being a case study for Europe that will help us think about how we respond to this as synthetic opiates start to impact more on Europe, which I think, unless we introduce a regulated heroin supply, is very sadly likely to be the case. But congratulations on the report. I think it's an excellent piece of work. And as with all these longitudinal projects that work over years, it evolves and grows over time, but it's a great start and really good success evolving over the first 4 years. So thank you and congratulations.
Thank you very much, Matt, for your insights and for your suggestions in regards to drug checking services and other stuff. Actually, our time is almost up. I think that we could stay behind just a little bit more. And we have a comment in our questions and answers box. It's in regards to access to HCV treatment. I completely agree with Perrine. Decentralization of testing and treatment from specialists to GPs and community is heavily needed. That's the comment that we have. And I would like to invite Rafaela back to maybe conclude today's webinar, and maybe you have some other things to add to what has already been mentioned. So
thanks a lot. Thanks a lot, Alexei and Perrine and Matt for your contributions. I think we have a lot of questions and a lot of comments that unfortunately will stay without us being able to discuss because of time. Time is short. I think it's something that for us is a learning process also for us, how to make this possible, this conversation, I think, in the next webinar. So I'm sure we will have other spaces and probably will produce other webinars to keep discussing all these questions that were brought up. But because we committed 1 hour to this and people are also expected to be here for 1 hour, so I think we will have to end this part. And I just wanted to thank everyone again for being here and for giving your support and present the results. Also to say that we have, I don't know if you have received in the chat, otherwise probably will receive via email later on, the place where you can find our report and all the executive summaries. They are all online. So we opted for not having a printed version. Should this need arise from anyone, then we can revise that. So we are open to see that as well. And for now, I just wanted to thank again everyone for your participation, for being here, and we continue this conversation in other spaces. And I think I just see now in the chat you have a link for more information if you need. So thank you, everyone.
Thank you.
And have a nice afternoon and night.
Thank you.
Thank you. Bye-bye.
Bye.
Thank you. Bye-bye.